this is a case that represents the challenges of the decision making in patients that have that are being treated for a pulmonary embolism. So we know that venous thromboembolism is a significant cause of mortality in patients with cancer. The risk of major bleeding when they are treated with heparin is less than 3%. However, in patients with cancer, this risk can be even higher. So we present this case that we had of the decision making regarding a colon cancer patient that was admitted with sepsis and pulmonary embolism and developed an intracerebral hemorrhage. So he's a 61-year-old man with past medical history of alcohol abuse, colon cancer, diagnosed 3 months prior to this admission that was treated on chemotherapy. So he presented with 1 week of fever, chills, shortness of breath, and he was admitted for sepsis. He was found with MRSA bacteremia and endocarditis from an infected port catheter. On the CTA, he was found to have a pulmonary embolism. He didn't have a right ventricular strain, and he was started on anticoagulation with unfractionated heparin drip. So on day 7 of admission, he had an acute change in mental status. He was barely arousable. He had shallow breathing, and he was intubated for airway protection. The CT brain showed an acute large cerebellar hemorrhage in the posterior fossa with compression and displacement of the right and fourth ventricle, and another one adjacent to the sagittal sinus. So you can see it on the first figure and on the second figure there on the right. The patient received treatment with protamine and neuroprotective measures because he was on the heparin drip. It was stopped. So he had a poor neurological exam with only preservation of brainstem reflexes. The ICH score was of 4 points, which represents a 30-day mortality of 97% and was deemed not a good candidate for neurosurgery. So the next day, the patient's neurological status was actually improved. He was awake, he was following commands. The hemorrhage was really not much changed from the prior night. And a neurosurgery decided to place an extraventricular drain. So he had a very long hospital course. He was complicated by renal failure. Eventually, he was extubated and recovered some functionality. However, bleeding, this is the primary complication of anticoagulation. So the treatment whenever you have some bleeding related to anticoagulation is reversal of the agents, of specific agents, and considering pro-hemostatic agents and modalities that may remove the anticoagulant. Specifically for intracerebral hemorrhage, we also have to do neuroprotective measures and emergent neurosurgery if needed. So this is a very complex decision because this patient has multiple risk factors to have complications from the VTE, and on top of that for bleeding. So on one side, you cannot have these patients anticoagulated, but on the other side, there's also very high risk of bleeding. So cancer patients with VTE are more likely to develop recurrent thrombus and major bleeding during anticoagulant treatment. So there are specific guidelines for oncologic patients. So in general, the treatment for cancer-related VTE is preferable with low molecular weight heparin, although unfractionated heparin, like the one that we use in this case, is more commonly used despite having more risk of bleeding in this population with cancer. So a personalized treatment incorporating risk of bleeding and preferences is essential, and the adjustments that need to be done and the choice of anticoagulation should be done based on the patient's characteristics. So but we always need future research to focus on optimizing the risk assessment tools and biomarkers to prevent this type of complications. Thank you.